Hi students, today we're going to address the vital case for global health investment. And this material comes from a reading that was initially on the syllabus for this semester by Sten H. Vermund and Ann Kurth, which was written shortly after the 2016 election. Vermund and Kurth are respectively a pediatrician and a nurse midwife. They're both deans at Yale University, and I wasn't able to include this as your reading given the transition to online instruction because there was not an online version available. So I thought I would present it to you instead. So the 2016 presidential election in the United States sparked a lot of concerns about whether the U.S. would withdraw funding from global health efforts that we were already involved in and slow the progress that had been made over the past quarter century. In particular, PEPFAR was a point of concern, and whether the U.S. would lessen its obligations through PEPFAR, which we've talked about before, stands for the President's Emergency Plan for AIDS Relief. There are, of course, people in the global health community who are critical of PEPFAR and some of its provisions, as we've also addressed, including the somewhat snarky nickname purchasing expensive pharmaceuticals from American retailers because of the strings that came attached to PEPFAR in terms of the requirement that purchases and financial benefits from PEPFAR should accrue to U.S. companies as opposed to being purchased perhaps locally where the programs were implemented, perhaps at a lower cost. So PEPFAR itself is not necessarily controversial, but for the purposes of this lecture, I do want to make sure to emphasize that it was and is a bipartisan program that was supported by both Republicans and Democrats in the U.S. Congress at the time that it was implemented during George W. Bush's presidencies. Vermund and Kurth, in their argument, argue that strengthening healthcare systems requires a long-term collaborative governmental investment and not mere charity. And that it's really important that we kind of break free of some of the historical tendencies to consider global health investments as charitable, as opposed to being investments in our collective future, or as, some would interpret it, investments explicitly in the U.S.'s best interest. Practitioners and proponents of global health widely agree that investments in health and development programs across the world are in the best interest of the United States, and think that it's important to recognize this and conceptualize this rather than phrasing it as some form of humanitarian charity. Using global health investments as a diplomatic tool has a very long history in international relations. It's not just a new thing, and it dates back to the 1800s, although we've definitely seen continued effort and progress in this sphere within the past quarter century. And in their article, Vermund and Kurth argue explicitly that these investments in global health are important for the national security and protection of U.S. citizens, where one considers the impact of a global pandemic of an emerging infectious disease, which we are all seeing all too clearly today, hence me delivering this lecture to you by video rather than in person. We see recently historically, that the Clinton, G.W. Bush, and Obama administrations emphasized the soft power of the U.S. government, including health and development, and that this is at odds with the vision of American strength projected through force and might by the Trump administration's America First ideology, which is characteristic of what political scientists and international relations scholars would frame as hard power rather than soft power. In their argument, where they are presenting the view that global health investments represent a major opportunity to simultaneously advance the core interest of the U.S. and improve the lives of millions around the world, Vermund and Kurth present four central tenets. The first of these is to enable rapid response and capacity building to control disease at its source. They used the 2003 SARS epidemic as a specific example in this, which incurred global cost estimated at $30 billion to $100 billion. Had the condition been recognized early and controlled, massive economic savings would have accrued in both Asia and around the world, and many lives would have been saved. Similarly, the 2014-2016 Ebola crisis killed over 11,000 people, almost all of whom were in West Africa. But even though only one patient died in the United States, the direct cost for core Ebola treatment centers in the US were at least $54 million, with total costs likely many times this for health department expenditures, screening and quarantine, and travel restrictions. In the three most affected nations, Ebola may have cost between $82 million to $356 million, which is a vast sum for low-income nations and the international donor community. The Ebola crisis in that time had a significant international response, but it was uncoordinated and inefficient in its work, and this was costly in terms of both money and social panic. Because health systems were so weak in the three most affected countries, again, Liberia, Sierra Leone, and Guinea, massive investments were needed to implement emergency response. This could have been alleviated by health system strengthening before a crisis, which makes health systems ready, responsive, and resilient in the face of a potential outbreak, as well as addressing existing healthcare needs. Prevention at its root sources is more effective and cost-effective than coping with pandemic spread, while addressing fundamental humanitarian concerns. This is a frequent refrain in public health, that prevention is cheaper than treatment and can lead to better quality of life and better survivalship than a model that focuses on treating people once they get sick rather than improving conditions so that people can stay healthier to begin with. Bermond and Kurth argue that waiting until the United States is directly affected to deal with emerging or imported diseases guarantees that the ultimate costs, both in the US and abroad, balloon with the increased complexity of disease control. And they further feel that we should have bipartisan consensus on this, rather than this being considered as a politically controversial view. The second tenet addressed by Bermond and Kurth is to protect the citizenry. Here, Bermond and Kurth address the globalized workforce and travel dynamics, which lead to a large number of Americans scattered across the world, either temporarily or in the longer term. For the protection of these citizens, prophylactic measures like travel vaccines and insect repellents can be helpful. But even more impact accrues with the control of diseases themselves in the countries lived in or visited, which impacts US citizens and local inhabitants at the same time. There's also a strong environmental health component to this argument, as waterborne, foodborne, and respiratory communicable diseases impact everyone, even though vulnerable populations are often disproportionately affected. This matters both in the short term and in the framework of averting catastrophic climate change. And Bermond and Kurth argue that isolationism and withdrawal from global environmental initiatives will only hurt the United States, along with harming other nations. The third tenet addressed by Bermond and Kurth is to conduct research into global health issues. Global health research is a good investment for the United States public sector because no microbe selects only certain human groups, and walls cannot keep out diseases. Walls are permeable. We live in a globalized society, and a disease that's a threat somewhere can soon become a threat everywhere. A given disease may be more common overseas, however, such that research could be done more cheaply and more quickly in that setting than it could be in the United States with its lower incidence. This has been historically the case for research on HIV, dengue, Zika, and RSV, which is a bad respiratory virus common in infants. This can also form the foundation for continued collaboration between researchers globally. The fourth tenet addressed by Bermond and Kurth is to emphasize soft power diplomacy to address humanitarian crises. The perception of the United States, the world's wealthiest nation, failing to respond to the challenges of global disability, disease, and death can fuel anti-US sentiment and complicate foreign affairs in economic, business, and political realms. The US can win friends and influence governments, however, by providing technical and concrete financial support for disease control and prevention, by enabling healthy pregnancies through birth spacing and contraception, and by reducing environmental hazards, all of which are tackled under USAID. Long term, strengthening health systems helps economies and thus weans nations from donor nation dependencies. Global trainees supported by the United States are typically friends and collaborators for life of US universities and agencies like the NIH, the CDC, and USAID. Furthermore, improved health can lead to greater political stability within and across countries, which can in turn result in greater economic development, local buying power, and economically benefit opportunities for US business and trade. However, all of this is currently intersecting with this historical tendency that threats to public health have been used as an excuse for anti-immigrant and racist policy that has become further amplified in the past several years. There are no communicable diseases that belong to a certain group. I will repeat, there are no communicable diseases that belong to a certain group. That's why we call them communicable. Overseas, risks are best tackled in the countries where they emerge, which protects US travelers and expatriates in those settings, even as the local community benefits, and prevents the spread to other areas. Most people in the United States, however, vastly overestimate the percentage of the federal budget that goes to foreign aid. In one survey, US respondents thought that it might be a quarter of the US federal budget, while in reality, it is less than 1%. Global health and development assistance is thus money well spent, improving health around the world, along with the health, economics, and security of the United States. In reflecting over this argument, I'd like to highlight that many students of global health at both the undergraduate and graduate level don't really like this type of argument. I'd like for you to ponder why. Do you find parts of this argument that emphasizes the benefits to the United States of investments in global health problematic, or do you think that it's a win-win for all involved?